Well, good morning, good afternoon, good evening, everybody, wherever you're joining us from in the world. My name's Martin Kiernan, and it's my pleasure to welcome you to another Weber Training Teleclass. TB seems to have been around with humanity for thousands of years. To me, it's a bit like Neil Diamond, something horrible that happened years ago, but it's never really quite gone away. Despite our advances in diagnostics, ventilation, respiratory protection, treatment, we still have problems with healthcare associated transmission, not only in the countries with a high burden of disease, but also in systems where TB is relatively uncommon and therefore clinical suspicion may be lower. So today's speaker is going to help us answer questions about when exposure occurs, difficult questions about who's at risk, how long should we consider somebody as exposed before we investigate, what control measures make a big difference. So our speaker today is Professor Mike Klompas, who's medical director at Brigham and Women's Hospital in Boston. He's a professor at Harvard Medical School, internationally recognized for his work in healthcare epidemiology and infection prevention and control. And many of you will know Michael through his influential research on healthcare associated infections, particularly respiratory virus transmission and evidence-based infection prevention policies. Today is going to be talking about a major systematic review looking at healthcare transmission of tuberculosis. Looking forward to this very much indeed. So welcome, Michael.
Lovely. Well, thank you very much. Thanks very much to Paul for inviting me. Thanks very much for Martin for hosting this. And let's dive in. So our topic of the day is nosocomial transmission of tuberculosis. And really the perspective I'm going to come at this today is that if you're running an infection control program, what constitutes an exposure? What sort of situations when you know that either a healthcare worker or a patient has TB, how you determine who in that person's circle needs to be tested for TB and followed up? That's really the question we're going to try to answer. And to do so, we're going to try to dissect what do we know about transmission of tuberculosis, particularly in healthcare facilities. What are some of the risk factors? What are some of the predictive factors? And what sort of might be an evidence-based or a reasonable approach to defining an exposure definition? Here are my disclosures. And here's our outline. So what's the risk of infection following nosocomial exposure to TB? How does TB actually spread, particularly in hospitals? What are the risk factors for transmission? What are protective factors against transmission? And ultimately, what kind of exposure definition should we use? I'm going to be basing my comments upon a systematic review that I had the privilege to complete with my colleagues, Dr. Fizza Mansour, Dr. Chana Ree, and Dr. Megan Baker, which was a systematic review of frequency, risk factors, and exposure conditions attending the transmission of tuberculosis in healthcare facilities. I really want to call out Dr. Fizza Mansour, who was the first author on this paper. She really did the lion's share of the difficult heavy lifting that underlies this review. And I also have taken advantage of some slides that she's put together in the past to help convey the findings that she found. So what was this? This was a search through the medical literature, Medline, Embase, Sinal, Cochrane, from inception through December 2024. And we were looking to identify case reports, case series, cross-sectional studies, cohort analyses of anything describing either patient to patient or patient to healthcare personnel tuberculosis transmissions in healthcare settings. We specifically were focusing on, again, patient to patient, patient to healthcare worker, not infected healthcare worker to patients, nor did we look at children. We did include all manner of healthcare settings, so acute care, clinics, and long-term care. And these were the factors that we sought from these articles, best we could find them, and evaluated. Contact factors, so things like exposure duration, how close one might be to the patient, whether mask and respirators are actually protective or not. Environmental factors, the size of the room, the relative pressure, meaning is it positive pressure relative to the hallway, negative pressure, neutral pressure, how many air exchanges per hour. Patient factors, how symptomatic is the patient? Does the patient have a positive sputum smear on microscopy? Does the patient have a positive nucleic acid amplification test that's positive? Does the patient have pulmonary cavitation on their chest imaging? And procedural factors, things like intubation, bronchoscopy, sputum collection, other kinds of procedures. So that was our dream list. That was our hope as to what we might be able to find and comment upon. What you'll find that is in practice is that we have better information on some of these factors compared to others, and I'll share that with you. Literature search, we identified through our lit search over 9,000 potentially studies of interest. after screening and exclusion of irrelevant studies or wrong study design or not having the right outcomes that we wanted, so on and so forth, we ultimately got down to 86 studies that were reviewed in detail for the factors mentioned on the prior slide. This is in terms of what we found. So in terms of locations, most of the data came from North America, Europe, and Asia, but with a sprinkling from other locations. And most of the data came from acute care hospitals, although again, about 1 in 6 of the patients of the papers dealt with other kinds of settings, such as clinic, psychiatric facilities, public health facilities, and so on and so forth. Now, strikingly, I began this discussion by saying we were trying to come up with an evidence-based definition for what constitutes a tuberculosis exposure. So just with regard to the time factor inside of exposure definitions, we found wide heterogeneity across these 86 studies. So 23 of the studies said any duration of exposure constituted an exposure and therefore merited evaluation for those individuals in contact with the infected patient or the infected person for development of tuberculosis. But we found a study that used a 1 hour contact definition, a 4 hour contact definition, an 8 hour, 24 hour, 2 days. And unfortunately, about 54, the majority, didn't even specify what their criteria was. And so that's a source of both a reflection of, I think, the lack of consensus across the field as to what ought to be an exposure definition, as well as you're also seeing over here a reflection of some of the weaknesses of the literature, that not everybody told us how they gathered the patients whom they tested and from whom they report a conversion rate. How is that group defined? So in many cases, that's left unsaid, and that is a weakness of the literature. So the first question I think we might ask is sort of our big picture question, was that at the bottom line, what actually is the rate of transmission inside of healthcare facilities? If there is somebody inside a healthcare facility, a patient who has unappreciated tuberculosis, what's the probability that another patient or a healthcare worker is going to actually pop up with tuberculosis after follow-up? And here's what we got. Across 86 studies with 1,083 index infections, so 1,083 patients who had confirmed pulmonary tuberculosis, we were able to identify almost 36,000 exposures, of whom 2,517 were infected, for an overall transmission rate of 7.1%. Meaning, taking no other information whatsoever, if you have a patient or somebody who's exposed to someone with tuberculosis, they have about a 1 in 12 thereabouts chance of popping up with TB. Of those who were infected, the majority, as you might imagine, were found to be latent infections, with only 8.1% actually having active tuberculosis that was found. So in other words, most of these detections come about through either purified protein derivative screening or more recently quantiferin release assays, so therefore we're able to detect latent TB. Now, the gamut of our study went all the way from the 70s right through to the end of 2024. And as you know, the way that we have dealt with TB in hospitals has really evolved over time. And just to give a couple of snapshots, this is only a partial list of some of the sort of the milestones along the way. This is successive guidance coming from CDC with regard to how to manage and minimize the risk of transmission inside of healthcare facilities. And over time, what we've seen is the increasingly more rigorous dealing of patients in terms of screening more aggressively, trying to put patients into first isolated rooms and then more recently into negative pressure rooms with high air exchanges. Over time, the amount of air changes we've required from those rooms has increased. Likewise, in the early days, a simple mask was felt to be adequate. More recently, we've moved on to N95 respirators. Our methods for detecting conversions, of course, has changed from PPDs to interferon gamma release assays. And of course, there's been change in the background incidence of tuberculosis, which also affects your detection rate. Right? And the challenge over here is that after an exposure, if you test a potentially exposed patient or employee and they turn out to be positive, is that reflection of sort of prior infection even before the patient exposure, or is it actually reflect a conversion? And so as the incidence of tuberculosis in our surrounding communities has fluctuated over time, we're at a period right now where things are better compared to certainly what they were like inside the 1990s. The likelihood of a conversion being a true reflection of a patient encounter is more likely. So some of the factors that play over here, both changes in guidance as well as changes in the interpretation of post-exposure screening. And so it's actually kind of worth chopping up that data on the overall transmission rate by time period. So amongst the studies that were published before 2005, which is when CDC put out their latest guidance on the management of tuberculosis in healthcare settings, the actual transmission rate was 15.2%, it's almost 1 in 6, remarkably. Since 2005, though, the numbers have come down substantially, so only a 3.8% rate of transmission. So that probably reflects where we are in the current era, under current conditions of ventilation and protective kind of measures that people are taking. The rate of transmission is only about 1 in 25. So again, I think that's useful context for any time you're actually about to embark upon an exposure definition, to have some sense as to what's the likelihood you'll actually be able to detect transmission. And if you have to counsel a patient who might have been exposed or a worried healthcare worker, again, this is good numbers to have in your back pocket in order to give some people a sense just from the outset as what the overall risk might be, not even taking into account the specific circumstances of their particular exposure. It's worth taking note of what we've learned about the spread of TB in the past 15, 20 years, what have you. You might say to yourself, TB is the scourge that's been with us forever. We know it well. It's the archetypal airborne pathogen. So what is there to learn about transmission? And it turns out we continually refine and improve our understanding. So, of course, TB does spread through the air. It is the archetypal airborne pathogen. But I think one thing that's worth appreciating is that there's a tremendous amount of diversity, of variety between individuals with TB as to how much TB they're actually putting inside the air. So this was a analysis of 96 different individuals with culture-positive pulmonary tuberculosis. And what they did in this particular study is they captured the air that the person was exhaling, and they measured, could they actually find viable colonies of tuberculosis inside that air? And I think the message over here is that the majority of people put out very little tuberculosis, but a small minority put out a lot, and some even put out huge amounts. Now, of course, it's not going to be difficult to imagine that this person over here on the far right, who's putting out a huge amount of tuberculosis, is probably much more likely to precipitate transmissions compared to others. It's a pattern we've seen with other respiratory pathogens as well. The same is true with influenza, with SARS-CoV-2, with RSV, the same sort of diversity. And those who are on the far end of the spectrum over here, who are super emitters, if you will, are also turn out to be the super spreaders, particularly when there are other conditions favorable to transmission. So recognize that not every person's the same. And while we're going to speak about generalities across the population of tuberculosis-infected people, there's going to be person-to-person variety. And unfortunately, there's actually not a particularly good way to work out who's likely to be a high emitter compared to not. So, for example, you might say to yourself, why not just look at the AFB on the sputum smear, and there's a ton of it. That person is probably more contagious. Turns out it's not quite so straightforward. So this is actually a household transmission study, just to bring out this idea between the mismatch between what you see on smear versus what might actually be inside of the air. So it looked at 442 household contacts of 96 patients with sputum culture positive pulmonary TB. And first of all, they quantified the AFB on sputum smear in a semi-quantitative fashion, 1 plus 2 plus 3 plus. And then amongst those individuals with each of these different quantities of AFB on the smear, what was the actual secondary infection rate in their household members? And you can see not much difference, despite the fact that some had a lot of AFB on that smear and others did not. However, if you actually measured the exhaled tuberculosis inside the air, then you did see a very good correlation. So the amount of exhaled tuberculosis was a very good predictor of high rates of transmission, much more so compared to those who put out small amounts of tuberculosis inside the air. And again, the reason why this is pertinent, first of all, it helps you better understand the biology. And of course, it makes perfect sense, right? That you're more likely to be infected if there's a ton of TB inside the air compared to simply in the person's sputum alone. But it's also, this is something that we don't have the wherewithal to measure on a routine basis inside of our patients. We can measure the amount of AFB on the sputum smear, but most of us don't have access to means to actually measure the tuberculosis that's actually inside the air. What about coughing? Now, coughing is one of the hallmark symptoms of tuberculosis, and I think most of us therefore presume that most of the transmission is a function of coughing. If the patient's coughing a lot, they're probably more contagious compared to if they're not. So is coughing the main mechanism of transmission? And some very sort of lovely work done in the past few years, quantifying the amount of tuberculosis bacilli emitted per breath under different kinds of breathing conditions. So this was a laboratory study on 38 people with pulmonary tuberculosis, and they had them do 3 different maneuvers. One is the forced vital capacity. So that is basically filling your air with your lungs with air and blowing out as hard as you can. It's basically trying to get a full lungs volume worth of air out of your body as quickly as possible. The second was tidal breathing. Tidal breathing is just ordinary, normal breathing. You're not doing anything particularly different or special, just breathing in and out in a calm, relaxed kind of a fashion. And coughing, of course, is coughing. But they measured the amount of TB inside the air. And I think a couple of messages emerged. First of all, there's a great deal of variety, as we've seen before. So some people put out very little TB, even with a forced vital capacity, in a forced exhalation. Whereas others put out a huge amount. And so there's a lot of overlap over here between the forced expiration, the tidal breathing, and the cough. And overall, collectively, while cough did account for the more tuberculosis bacilli inside the air compared to, say, tidal breathing, if you think about it, and they actually measured this inside the study, we do a lot more breathing than we do coughing. So as part of the study, they did 2 things. On all those 38 individuals, they actually measured their breathing rates, and they found they took a breath about every 4 seconds, about 15 times per minute. And they counted the number of times they coughed over the course of the day. Of course, there's some variability in those parameters, but if you do the math as they have done, and I've reproduced for you over here, if you're taking 15 breaths per minute over the course of a 24-hour period, you will breathe 22,000 times. And if you cough amongst these individuals with pulmonary TB, the coughing average number of coughs per day was 466, with a high in the 500s. That's fractional compared to the amount of breaths you take per day. So even though you're putting out a little bit more tuberculosis inside the air when you cough, you're spending much more time breathing. So that collectively, the cumulative quantity that you emit is much more related to your tidal breathing compared to your coughing. So lack of coughing is not reassuring, and coughing unto itself is only a small addition to your overall amount of emissions. Here is their quantification of this. This over here on the bottom of the horizontal axis is the number of coughs per day. This is reflecting the diversity inside this tested population, where they went from a low of around about 50 to 100 coughs per day up to a high of around 550. And even if you're in the high range over here, coughing 550 times per day, the total amount of TB you put inside the air was fractional compared to the amount you put out through your tidal breathing. Okay, what do we know about some of the correlates of transmission, some of the predictors of transmission inside the healthcare facility? And I'm really talking here about care factors. So this is collated here from 3 different studies. And this is no surprise. The more care you provide and the closer care you provide, the more likely you are to end up being infected. So here are some of the proxies that they were able to identify. The number of clinical notes written in infected people was 3 times higher compared to those who were not infected. The number of medications administered over here also 3-4-fold higher amongst those who were infected compared to not. And those who got infected worked more shifts compared to those who did not. And the similar data also looking at the number of room entries, for example. The more times you enter the room, the more likely you're to be infected. So more frequent care and more proximal care, so administering medications might be a proxy for that, are associated with increased overall risk. The other factor is amongst patients. Of course, the big risk factor for TB transmission between patients is sharing a room. In terms of quantification of that, they were able to identify 593 exposures of people who shared a room with another patient who was infected, and the transmission rate overall was 2.9%. And I think, again, helpful context to have in those unfortunate situations where you have to tell a patient that the person in the bed next to them turns out to have tuberculosis that was unbeknownst to the system, and therefore that they were at risk. But their overall risk, as you can see over here, is quite low. Some of the protective factors are really distance. And why is that? Is because with distance, you get more and more dilution and diffusion of your emissions of tuberculosis, basically diluted by the surrounding air. And so the overall amount of TB to which you might be exposed is going to be diminished. This is borne out in some very nice epi work over here, looking at an association between room location relative to the person with TB and your risk of acquiring TB. This was an unfortunate and I think very unusual situation where there was a patient who had a large TB hip thigh abscess. So TB actually causing a big old abscess inside the person's thigh. And the person was accidentally placed inside a positive pressure room, and they were doing bedside irrigations where they're basically using like a water pick kind of technology to spray the wound itself in order to clean it. So it's a perfect setup for transmission because the abscess itself has a very high bioburden of TB. It's basically pure tuberculosis, concentrated and in one sort of big location over there. And you're spraying water on it, which leads to aerosolization of the TB from this infected abscess. And in this instance, it was positive pressure. So an extraordinary and unusual kind of a circumstance, and led to a lot of transmission inside of this ward. But they were able to show a very nice step function in the probability of infection as given your room location. And the further and further away that you were from the index patient over here in room one, the less and less chance you actually had of infection. How about masking? So masking, of course, does decrease risk. And even a medical mask will provide some protection. So a couple of studies looking at this. One looking at the rate of infection in wards that use routine surgical masks versus not. You can see that those who did wear medical masks had a much, much lower rate of infection compared to those who did not. And another study that reported on house officers who were working in a tuberculosis ward and were instructed to start wearing medical masks. And this is a published in the early 90s. So we're again reflecting sort of a very an older era before CDC started to recommend respirators for routine care of TB. It is interesting to know that even for TB, the archetypal airborne pathogen, there was a period where public health recommended medical masks alone for the management of TB. And anyway, in this period, though, that turned out to be helpful. So 0 transmissions amongst 52 exposed physicians working in a tuberculosis hospital for 6-week periods. You might say to yourself, well, maybe those data showing protection with medical masks are really just surrogates for other kinds of behaviors, that those who chose to wear medical masks were careful in other kinds of fashion. So this is one of my favorite studies over here, which is a randomized trial actually looking at the protective power of medical masks. And this was done inside of South Africa, where they took 17 patients with tuberculosis on a TB ward, and they were randomized to wear masks on alternate days. And then depending on if it was a mask day or a non-mask day, the ward air was funneled to 2 different groups of guinea pigs. So there was the guinea pigs exposed to quote-unquote masked air, and the guinea pigs who were exposed to unmasked air. And what they found was amongst the guinea pigs exposed to masked air, the rate of infection was 40%. Amongst those who were exposed to unmasked air, the rate of infection was almost 80%, so almost double. So masking patients was associated with a 56% decrease in TB transmission to guinea pigs. Now you might be saying to yourself, I mean, how can this be? How can it be that a medical mask is actually protective against an airborne pathogen? And the answer is because a medical mask does provide some degree of filtration. This over here is a quantification of the filtration efficiency of a surgical mask or a medical mask compared to an N95 respirator. You can see a surgical mask will block out around 38% of emissions compared to a respirator blocking out 99%. But nonetheless, that means that's 38% less TB that's getting inside of the air. And that kind of fits with about a 50% decrease in the rate of infection inside of those guinea pigs. And also fits with the lower rate of infection that we saw in healthcare workers in those 2 prior observational studies. So we really need to let go of this dichotomy of airborne versus droplet pathogens. Just like we've come to learn that all pathogens are spread across a continuum of respiratory particle sizes, so too a medical mask is not a nothing, even for an airborne condition. It does provide some degree of protection, and it's really closely associated with this, basically how much filtration efficiency does it provide. Blocks around 40-50% of emissions, or decreases in inhalations by 40-50%. So therefore also decreases transmissions or infections by around 40-50%. And we've seen the same is true with respiratory viruses as well. But nonetheless, we do have data showing that respirators, as you could imagine, do provide better protection compared to a medical mask with tuberculosis. This is a study from China, looking at the Chest Hospital inside of Beijing, where they analyzed 392 healthcare workers with regard to the kind of respiratory protection that they were wearing. It's amazing to me that in 2018, that people working in a TB hospital or in a chest hospital might not have been wearing respirators for all patient care, but go figure. Amongst those who did wear N95 respirators, there was 0 TB conversions, whereas those who wore either a gauze mask or a medical mask, 68 out of 177, so about a third, ended up getting infected. When they did the adjusted for other kinds of individual healthcare worker factors, they found the adjusted odds ratio for infection with a medical mask or a gauze mask versus an N95 was an astounding 47-fold increase in the odds of infection. And you can probably say to yourself, those who did wear N95 respirators were probably those who were in riskier circumstances, right? They were probably those who were providing direct care for a patient with known tuberculosis, for example. And so I would say that, if anything, this is probably a conservative estimate of the relative protection of one versus the other. How about ventilation? It certainly also decreases risk as well. A couple of studies looking at that. So this is data from Canada, looking at associations between air changes inside of the hospital compared to the rate of TB conversions over the years from person's original hire. So they identified 17 different hospitals and they characterized the air change rates inside of their patient rooms, and then tracked these healthcare workers over literally almost 2 decades to see what happened to them. So the black line over here is sort of the baseline. This was the rate of TB conversion in non-clinical hospital workers, like administrators or people who did not have direct patient care. And that sort of, it gives you some sense of what the background rate of TB acquisition is over a 30-year period inside of a general population who's not actually looking after TB patients directly. Amongst clinical staff, though, who were seeing patients who might have had TB, if they were working in settings with less than 2 air changes per hour, you can see the survival distribution function, meaning that the probability of remaining free of conversion to TB was this. In contrast to in green over here, clinical staff working in settings with 2 or more air changes per hour had a much lower rate of conversion. In fact, their rate of conversion is pretty similar to the non-clinical workers. So it seems like that's your minimum threshold. You have to have at least 2 air changes per hour to get into this space where TB transmission is substantially diminished. Now, it's not eliminated. The green line is still less than the black line, but that gives you some sort of sense of that even 2 air changes per hour is enough to put you on a safer basis. How about 6 air changes per hour? So here is the same study, now stratifying the population to clinical staff who worked in settings with less than 6 air changes per hour versus those with 6 or more air changes per hour. And again, we have our baseline over here for non-clinical employees over here, giving us the background rate of conversion amongst those hospital employees over here. And what you can see again is that clinical staff working with lower rates of ventilation do have a lower survival function, meaning less probability of remaining TB conversion free. It's better if you have more air changes per hour. But I think the striking thing point is that the difference over here between the green line and the red line is much less compared to what we saw on the prior slide with where we cut the point of differentiation at 2 air changes per hour. So 6 air changes per hour is better, but it's not a whole lot better compared to 2 air changes per hour. And so that gives you some sense as to what the impact of ventilation. And a closely related factor is the actual room volume. Right? The bigger the room, the more space, the more volume in which those TB tubercles can distribute, and therefore the lower concentration in any one location, and therefore the lower amount of TB exposure you're going to get from being inside that room. The concentration inside that room is going to be less. So this was an analysis of tuberculosis conversion rates among 71 healthcare personnel exposed to an infected patient. And we have over here the size, the volume, each room's the room cubation, as they put it. And this is inside of cubic meters. And then the proportions of people working in these different areas who had a tuberculin conversion. And putting it all together, they were calculated that for every increase in 1 cubic meter in the volume of the room, there was a 3% decrease in the odds of tuberculin conversion. So 3% decrease in the odds of transmission. And of course, brevity decreases risk as well. This was the contact duration amongst those studies that reported how long an exposure actually took place for amongst those who did convert to acquiring TB inside of a healthcare setting. For healthcare personnel, the median exposure duration was 24 hours, so a full day. And the interquarter range was not too different, 24 to 25 hours. And for infected patients, same deal. despite the fact they're in the same room, a median exposure duration of 24 hours, slightly wider range of interquartile range of 12 to 24. But again, the take-home message over here is that you're very unlikely to get TB from a 10-minute or 15-minute passing encounter. We're really talking about hours and hours worth of exposure that is associated with most transmissions inside of healthcare settings. Here's a further demonstration of that same phenomenon. Again, this is across all the studies that were able to identify that commented upon the duration of exposure in those who acquired infection, either patients or healthcare workers, from a patient with unappreciated pulmonary tuberculosis. And yellow over here is 0 to 8 hours worth of exposure. Orange, light orange over here is 9 to 12 hours. Darker orange is 13 to 24 hours. The red over here is 25 to 48. And the dark red is 2 to 7 days. The net take-home over here is that you can see that less than 10% of transmissions are taking place with less than 8 hours worth of exposure. And so if you had less than 8 hours worth of exposure, it's very unlikely. It's not impossible, but it's very unlikely that you're going to get tuberculosis. How about some of the patient factors? So smear positivity. Exposure to smear positive patients was associated with more patient transmissions. Now, we saw before how smear positivity is a weak correlate of transmission risk, because really what you want to know is the amount of tuberculosis inside the air. But in this particular study, they only gave us the smear positive versus smear negative result, not the actual quantification of tubercles inside of the air. And they actually looked at patients undergoing deep respiratory suctioning and found similar transmission rates amongst those undergoing deep respiratory suctioning, regardless of if the patient was smear positive or smear negative. So smears is not a particularly strong predictor, but it does have some sort of association with transmission risk. And unfortunately, we could not find any direct comparisons of transmission rates in cavitary versus non-cavitary pulmonary disease in the source patient, the presence or absence of respiratory symptoms, or the results of an MTB PCR or nucleic acid amplification test result. So unfortunately, we have data on some of that from outside of healthcare, but did not find inside the healthcare review itself. This study was really marked by, I think, we learned a lot, but there were a lot of limitations that we discovered inside the literature. In many cases, there was no direct comparison of one risk factor versus another. And most of the studies were small, did not adjust for a confounder. So, for example, if the study was looking at size of room, for example, it didn't take into account, well, what were the difference in terms of the amount of time you spent inside of the room, or the nature of your activities relating to the patient inside the room. And so that means that there's potential for these associations to be biased by some of these unmeasured, probably important factors as well. And there was a great diversity inside the literature of exposure definitions, the ventilation standards that were in practice at the time that the study was done, the index patient characteristics, amount of follow-up, etc. And finally, there undoubtedly is publication bias. The more unusual and striking transmissions are more likely to be published compared to plain vanilla, ordinary, workaday exposures inside of the hospital. And that works kind of both ways. I think that there are a couple of studies we did come across with transmission under very sort of unusual circumstances. So a few minutes in the waiting room, there's one study that reported on that possibility. It's so unusual that's publication worthy, but that could potentially skew these kinds of results. Likewise, the converse. If you had a patient who ostensibly appeared to be highly infectious, and yet there were very few transmissions, that might also be deemed publication worthy to try to give people a sense of maybe TB transmission is not as bad as possible. So you can see how the bias could work in different kinds of directions depending upon the nature of the event and what you feel is publication worthy. So that's a grain of salt to take with this entire analysis. So putting it all together, this we think is a potential exposure definition that's pretty conservative, but also probably less aggressive than what many hospitals are using now. So at least 8 hours of cumulative exposure. And again, you could probably go up even beyond that and still be in pretty safe ground. But we found that less than 10% of healthcare workers or patients who acquire TB had less than 8 hours worth of exposure. So that's where that number comes from. Obviously not wearing a respirator. And the caveat over here is that this assumes that we're in the contemporary era, the 2005 plus, where we do have contemporary ventilation standards at way. If you're dealing with a facility that is still stuck in the 1990s with less than 2 air changes per hour, Of course, this is going to have to be modified accordingly. But in terms of where most of us are at right now, I think this is sort of a reasonable place to land your hat, and recognizing again that even under these conditions, um, transmission in the current era under these sort of circumstances is very low. We saw less than 4% overall. And with that, I thank you. And I tossed into Google Gemini. I said, "Give me a picture that represents TB transmission healthcare facilities." This is what it came up with. But based upon what we've sort of discussed today, this lady over here, this elderly woman sitting to the left of the person who's sneezing up a storm over here, how worried should she be if in fact that person has tuberculosis? And I think what we come to understand is that despite the fact that she's right next to the chap over there, probably her risk of transmission is quite low by virtue of the fact that hopefully she was not in the waiting room for a particularly long period of time. So although this looks like an awful situation if you found out this person had TB, and if it happened in my hospital, we'd all be flipping out with the exposure investigations we'd have to do across this large waiting room. Nonetheless, her risk of transmission was probably low. Also, it looks like quite a big room, and that also would be a mitigating factor. Okay, and with that, I'm going to stop and welcome discussion from Martin and Paul.
Thanks very much, Michael. I actually like that picture. My first impression, actually, of it was the guy in the middle is having a sneeze, not a cough, and the lady deep breathing in shock beside him might be the one who's actually emitting more.
Maybe you're right. Maybe you're right.
That's what I was wondering. Now, do you think, because you've covered a wide timescale here for all the papers you've had to look at, have we got any better at reporting duration of exposure and some of the other factors that might be more helpful to us? Because I can imagine papers from quite a period ago may have been a bit skimpy on the detail.
No clear improvement. There's really a variety. A lot of these papers comment upon events taking place in the 1990s, when there was, as you recall, sort of great concern for the spread of multi-drug resistant tuberculosis associated with the HIV epidemic. And under those circumstances, that led to a lot more of work in this particular space. And some of those analyses are quite detailed. But I think if you wanted to sort of take what you're saying and say, well, what can we learn? What should we be putting inside of future papers around analyses of TB transmission events? I mean, I really want to know all the factors that we commented upon today. I want to know about the patient factors. What is their respiratory symptomatology? Were they actually coughing? Did they have a cavitary lesion or not? Were they smear positive? Were they TB nucleic acid amplification test positive? What was the nature of the environment that they were in? What was the size of the room? What were the air changes per hour? What was the flow of positive versus negative versus neutral pressure? I want to know about the nature of actual care provided. Were you simply, is this a psychiatrist's office? Was this providing close care at the bedside? Was this a person who was debilitated and therefore required a lot of hands-on assistance? How long did that exposure actually take place? And what kind of respiratory protection were you or were you not wearing? Mask, respirator, or none of the above. So those, I think, are all the pertinent factors, and it would be a rare and precious diamond of a study that was able to report on all of that, as well as have enough numbers to be able to adjust and control for all those factors to give us a little bit more clarity as to what some of the factors might be.
You beautifully preempted my next question, actually, which would have been, should there be a template of a minimum data set for reporting TB outbreaks? And I do wonder if people aren't bothering to report now because they think the work has been done without realizing that actually it really hasn't. And even if you could get a few smaller studies together, then eventually you would get enough to do a better analysis of a collection of samples of studies if they were all done in the same sort of way. So I think you gave a very nice list there. I don't know, I haven't unfortunately read the paper, but did you actually put that in as we would like to see this? Here are gaps in the literature.
We pointed out those gaps. We never took that additional step that you're saying of this should be the standard for analyzing and reporting on a tuberculosis cluster in the future. Yeah.
Okay. I'm just wondering about the super emitter thing. Because hardly anyone is, so most people are not. I just wonder if there's any sort of modeling that could be done. I think back to the virus that should not be named anymore, but speech volume was found to emit more into the air. Are the super emitters, and we won't know this, but do they talk louder? Because I think people taking deep breaths to speak loudly are generally going to be using more it's going to be more of a forced vital capacity rather than just the normal breathing, or just smoking make a difference, or lung capacity, or exercise, or things like that. I just wonder if there's some sort of modelling that could be done to actually work out potentially who might be a super emitter and help us, because as you say, we can't screen everybody's breath to determine if there's much in the way of TB in it.
Yeah, no, I don't know. I haven't seen that kind of work done. So I think I think we'd love to be able to work out who those super emitters are, and it's an interesting sort of question as to what you would do once you knew that somebody was a super emitter, so if you would handle them
Yes.
differently or not.
Yeah.
But I think it's also worth just pointing out, though, that a super spreading event probably requires additional factors. So in addition to the person putting a lot of tuberculosis inside of the air, even more so than with regard to the virus that shall not be named, it's really important to have other factors in play as well. So a poorly ventilated space, a smaller space with lots of people who are vulnerable inside that space. And over here, because we're talking about, with respiratory viruses, exposure periods of 15, 20 minutes, what have you, might be enough for many people to get infected. Over here, we're talking about hours worth of exposure. I think what that means is that the ventilation factor becomes that much more important. Like we say, for example, for a respiratory virus, that ventilation doesn't really make a difference if you're right in the person's face, because there's not enough sort of time or space for the ventilation to decrease the concentration of virus inside the air. Tuberculosis might be different. It might be that ventilation takes on a enhanced role of importance, because it's really sustained exposure that appears to lead to transmission, as opposed to these sort of brief exposures. So even if I'm sort of in the person's face over there, it's because I typically am not going to do that for 8 or 9 hours at a time. The amount that's accumulated throughout the entire room space probably is a better predictor of my overall risk. And that in terms is a function of, again, just dwell time inside that room, as well as the quality of ventilation inside that room. So I think that we could take on much more importance with this pathogen compared to respiratory viruses.
Yeah, I mean, the air is interesting, isn't it? Because where you showed, once you got to 2 air changes, the clinical staff and the clerical staff are broadly similar. I was wondering actually if there's much recirculating of air going on in that particular area as compared to an area with no air changes at all. Were there any findings in this review that really gave you a bit of a surprise, or affected any preconceptions you may have had up until now?
So I wouldn't have predicted that 2 air changes would be enough. So that was sort of a lower estimate than I might have imagined. But okay, that's good to know. I do still think that 6 was superior, but nonetheless, it wasn't. The difference was less marked.
Yeah, that was interesting, because generally you think more air changes is less transmission, and that one, there seems to be a sweet spot there. Do you think hospitals generally know exactly how many air changes they got in every room in their organisation? And would that be something you'd recommend that people would start doing baseline work on, so that they could then factor that into contact investigations?
So that's an interesting question. I mean, the hospital's supposed to be designed to a certain standard to meet the requirements for a healthcare space. Typically, per CDC recommendations for most clinical spaces, it's at least 6 air changes per hour. More in other kinds of specialty kinds of areas, like a bronchoscopy suite or an operating room, so on and so forth. So
I was more thinking on a global. I was more thinking on a global. In the States, you've got certain standards. We would have standards here in the UK. Some hospitals were built before we have standards, or the existing standards. So, is this something though that people should have a feel for in their own organisation?
Definitely want to have a feel for. The other factor though is that you can have your design standard, and you have the way that the place was actually set up. Things change over time, and so what might be worth doing is, if you do discover a person with, say, pulmonary TB, it's a high consequence situation where there's, say, many people who are exposed, and you need better insight. So go at that time and measure the air changes inside of that particular room to give you some sort of proxy.
Yeah. Yeah, I mean, people build onto hospitals, don't they? And then we don't always know exactly what that does to the ventilation system in the organisation.
Well, I mean, some hospitals, I mean, they're constantly being rebalanced, right, in order to try to do one thing versus another in one area versus another, and particularly if there's any kind of construction or renovations that's taking place, these are constantly in flux. So again, it is helpful to measure at least once, to have a sense of where things are, but don't assume it holds true as a constant throughout time. It needs to be rechecked if
Yeah.
it matters.
Yeah. Okay. I mean, plenty of hospitals, therefore, are still going to be doing some quite large contact investigations, and you're suggesting maybe a cut-off at 8 hours. Do you think these findings should be used now to have a more targeted approach, right? Because I've spoken to Hilary Humphreys in the past, who showed the enormous amount of time taken up by infection prevention teams doing all the contact tracing, etc. Could we
Yeah, it's
spend
very
our
true.
time better?
Yeah, I think so. I think so. I think first of all, if you're sitting right now still with a 15-minute or 1 hour exposure time for your exposure definition, that's nuts. You should definitely let go of that. I think also it would not be crazy to even start with, say, a 24-hour exposure period and do this in a concentric circles. If you find no conversions amongst those of 24 hours worth of exposure, maybe you can stop at that point and only go on to people with less exposure time if you actually find conversions. I mean, that I think also, if you're dealing with either many sort of exposures or a very large exposure, that can be one way to make it a little bit more tractable.
I was wondering if there's some sort of algorithm, really. It's 8 hours, but in an area with more than two air changes, then you can be reasonably relaxed about that. But over 8 hours in less than two
Yeah.
air changes, then you're going to be thinking, well, okay, maybe we need to go a little bit further.
Yeah, I think that's true. And different public health jurisdictions do have tables of that nature. It does
Mm.
exist.
Okay. If you could therefore only invest in one intervention in your organization, you can either improve the ventilation, or you can give people better personal protective equipment, or you can diagnose more quickly. What do you think would be the biggest bang for buck in terms of reduction in potential transmissions and workload, etc.?
Well, I think the biggest big bang for the buck would be ventilation, because I think that has broad benefits in tuberculosis, but for other pathogens as well, and for the general health of the environment. So I mean, I think, and we always favor modification of the environment over trying to change individuals' behavior, because it
Yeah.
simply is just a much more effective kind of pathway to making sure benefit is accrued. So I think that's where I would start. Better diagnostics is interesting. No question. So if you have better diagnostics, the amount of time this person spends with tuberculosis before detection is going to be diminished, and therefore less exposure taking place. The subtlety in that one is that typically we only deploy our TB diagnostics once we suspect TB. And once we suspect TB, we typically will have that patient on airborne infection isolation.
Mm.
So they'll be inside of a negative pressure room. We'll be wearing N95 respirators. So by the time you get to sort of cross that threshold saying, I got to test this person, you probably have eliminated the risk at that point onwards, because you now have the person inside of a protective environment and you're wearing the appropriate respiratory protection. So there are other benefits to better diagnostics, more rapid diagnostics, which is really turnover in the healthcare system. So you don't have people with low probability TB who are tying up your limited airborne infection isolation rooms, for example. If you're able to get those people out of that sooner, that could be beneficial just in terms of maintaining your patient flow. But it's unlikely to be sort of a point that mitigates risk until and unless we identify more agnostic kind of testing technologies that'll basically be testing everybody for TB if they have a respiratory syndrome. So this would be an
Mm.
extension of what we currently have now with multiplex PCR for both bacterial and viral pathogens. So you could imagine, could there be a world in which it would be worth having a TB component to that as well? That would certainly reduce, I think, unappreciated case of TB, although all sorts of questions around what actually is the performance of that in terms of sensitivity, specificity, risk of false positives if you're testing sort of broadly in that sort of fashion. What's the cost effectiveness of that? What actually is the feasibility and cost of that technology? So that's just me sort of doing a little bit of blue sky dreaming, but I'm not sure if that actually would be viable or not.
Okay. I'm going to ask you to do a bit more blue sky now. If I
Ah,
gave you a large sum of money to do some research, what would you do it on? If you had, what study would you really like to see appear within the next 5, 10 years or so?
on tuberculosis transmission.
Mm.
Whew.
What would help,
Um,
do you think? What would help us most?
That's a nice, very nice question. I'd have to sit down and really think about that. I think that's if there was sort of a golden ticket like that, I don't think I want to sort of answer in a willy-nilly kind of a fashion.
Mm.
Um,
Maybe I should have made it a silver ticket or something like that. Because I mean,
Yeah.
because I was interested in the time of exposure, but 8 hours does seem to be the sweet spot, you know. And I'm not sure doing a study would help us much, because I think it would depend on how many people are emitting. You know, what's the emission status of people, wouldn't it? It'd be quite difficult to work
There
that
is a
out.
sort of this blue sky dream that that's out there, which is having pathogen detection monitors inside of the clinical spaces in every sort of clinical room, that's
Mm,
continually just checking the air and seeing what is actually inside the air. Is it influenza, RSV, tuberculosis, whatever the case may be, and sort of being able to flag on an immediate basis what might actually be happening over there. So that could be kind of a transformative technology, which is that
yeah,
you room the patient, and all of a sudden the room tells you, oh, there's a case of influenza, or
we've had
oh,
someone
there's a case
through.
of
Yeah,
tuberculosis, or
yeah,
if you just borrow, there's this interesting literature on exhaled organic signatures of different kinds of bacterial pathogens. So might even be able to say this patient has Pseudomonas or Aspergillus inside of their lungs as well.
yeah.
So basically, a smart air detection technology inside of rooms. There are all sorts of sort of complexities that attend this, and logistical questions that are with, sort of we could elaborate another time and space over there. But in
Yeah.
principle, that could be, I
Yeah.
think, a transformative technology.
Yeah, I was wondering if there was something like because people emit volatile or VOCs, don't they? If they've got particular infections, and dogs have been trained to spot E. coli in urine and Pseudomonas and things like that. Is there something like that,
Right.
but in the future? But
Right.
one thing I also wanted to ask is, if your ventilation, if you go around your organisation and you've got a medical ward to where your TB patients, potential TB patients, may be emitted, and it's old, and you can't do anything about the ventilation, would you consider putting portable air filtration in those areas to try and help? Is there any evidence to support that at all?
So older recommendations did include that possibility.
Mm,
In principle, it should work, right? Anything that you're doing that's cleaning the air is going to decrease the concentration of, in this case, tuberculosis inside the air, which will decrease risk. What we learned in practice, I think, during COVID, is that those machines work well in theory, but that if they're noisy or get in the
yeah,
way, then
yeah,
people unplug them or roll them away, and they don't
yeah,
work when they're not on. That I think is something I can definitely tell you.
yeah.
So,
The staff
so
get annoyed by them, don't they? And the patients don't like the noise at night. So
right.
maybe that's something to think about. Okay, well, thank you so much, Michael. I've thoroughly enjoyed the discussion. You've highlighted the current status of the literature. I do think there's an enormous potential for reducing the burden on contact tracing if you know exactly what's going on in your organization with regard to airflows and exactly how long people were exposed in certain areas from. So I think that's really useful. Paul, can we go on to the next slide, please? I think I can do that. Yes, just to highlight our upcoming teleclasses over the next few weeks. Firstly, we've got a long-term care preparedness for the next pandemic, getting ready. Then we've got national and local improvement steps for infection prevention, what it takes for success. Both of those are in July. Moving into August, what's our role in preventing infections across borders, which is very interesting going on, and that's an IFIC teleclass. Looking at HIV prevention through community pharmacies as well, lessons from implementation in Africa, in South Africa. So that's what's coming up. Thank you very much. And just to highlight our teleclass education patron sponsors, without whom teleclass education could not take place. So that's Diversity, Virox Technologies, and the International Federation of Infection Control. And before I go, I'd just like to thank Michael again and just point out that Michael is actually doing a Bike for Chai challenging cycle event for children and families of the Chai Lifeline, which helps children who need emergency financial assistance and transportation to medical appointments, etc. So if you want to help Michael, it's Bike for Chai. You can find that on the web and just look for Mike Klompas. Thank you again, Mike. It's been a fantastic session. And thank you, everybody, for listening. And wherever you are in the world, I hope you got something out of this fantastic teleclass. Good day to everybody.
Lovely. Thank you.